changes in some states' use of quarantine orders. I just thought I'd very briefly say that we here in Iowa have put together our isolation, quarantine, and self-monitoring orders several weeks ago. We do not anticipate doing any changes to these. They are the same as we discussed with you last week, and that our protocol is consistent with the CDC guidelines and with Iowa law, and to be honest, consistent with the way we've used it in the past. Just to clarify, though, a couple things. In Iowa's law, it does say that we need to use the least restrictive way in which to have the person placed into isolation or quarantine, and it does say that a person cannot be fired from their job if they are complying with a public health order. So if you get any questions about that, that should be your answers. So I wanted to just now give you a little bit of an update on what's going on in the world. First of all, in West Africa, we only have 3 countries at this time in West Africa that are have Ebola transmission. 3 of them have widespread transmission, and that is Guinea, Liberia, and Sierra Leone. They still remain the main countries that we are concerned about with travelers coming back, and unfortunately the numbers continue to go up. We are over 10,000 cases now. And just to remind you, there are a couple of remote districts in the Congo also that are having typical rural types of limited spread outbreaks going on also. So if we look at the countries which have travel-associated cases and localized transmission, one of them is Nigeria. It has now been declared to be Ebola-free, so Nigeria does not have any Ebola there, no transmission. People coming back from Nigeria will not be under any extra restrictions at all. They'd be treated like anybody coming back from any other countries. Spain, as you saw, did have 1 case, and then we in the United States are up to 4 total cases with 1 death. So this is of concern, but again, the main countries we are concerned about and that you'll probably be hearing a lot more about in the future and from us are the 3 West African countries. This is a very, very busy slide, but I just wanted to put it on for the impact because this is all of the information that has been put out by CDC since our last conference call. You can see there's a lot. I wanted to bring basically 3 to your attention. One of them is there is now an infographic or a flow chart called Identify, Isolate, and Inform Emergency Department's Evaluation and Management of Patients with Possible Ebola Virus Disease. There's both the chart and narrative guidance that some of you might find very useful. It does talk about what kind of PPE to wear, etc. So that's one you might want to pull out. Another one is a poster that was put out by CDC called Ebola, What is the Difference Between Infections that Spread Through the Air and by Droplets? This is something we've gotten a lot of calls on. So it's got some nice pictures about what is the difference, etc. That might be something that you might want to pull up and either use yourselves or provide to your healthcare partners. The last one, we've gotten a lot of calls in the past, and there is now a fact sheet and information on Ebola-associated waste management. So that's another one that you might want to pull up and take a look at if you're getting those questions also. But again, as you can see, a lot of things have been either updated or have come out, so you might want to take a look at the whole list. But those are the 3 that I thought might be most useful for all of you out in the field. Okay, we thought we'd also do a couple of questions. We're getting a lot of questions, but these are 2 of the most popular ones, so we thought we'd just go through them. One of them is everybody traveling from Guinea, Sierra Leone, and Liberia at risk for Ebola? And the answer is no. People who have been to these countries in the past 21 days but have not been around people who have Ebola are at very low or perhaps even no risk of developing Ebola. However, people who have been to these countries in the past 21 days should be assessed for the risk of developing Ebola and, if appropriate, monitored for symptoms of Ebola. The thing to remember is there are whole parts of these countries where there is no Ebola still, particularly in Guinea. So again, we need to use a little bit of science and understand what the risk is and what it's not. And again, Anne's going to go through a little bit later just how that screening is occurring. Next slide. Another question we're getting is, do people need to be excluded if somebody in their household or a close contact recently returned from Sierra Leone, Guinea, or Liberia, particularly in the last 21 days? And we've particularly gotten this around students for some reason. So the answer here is also no. In this situation, the student or the family member poses no risk to others at the school and needs to go ahead and continue his or her education. If an Iowan or a visitor is found to have been exposed to a confirmed case of Ebola, whether that occurs here or in another country, that person will be put into quarantine before they would have any risk of spreading the virus to others or contaminating the environment. So just remember that public health officials, all of you and us, we will accept the responsibility for doing the assessment about who has been exposed or potentially exposed to the Ebola virus. And we will determine what actions are appropriate and ensure that those actions are carried out. And all of these actions are designed to protect others in the community. We don't need other people in the community, schools, businesses, etc., to do that assessment. If they have concerns, they need to let us know. As public health officials, we will be the ones to determine whether or not somebody needs to take additional action to protect the public. So now I'm going to turn it over to Dr. Ann Garvey.
Great, thanks, Patty. So I just have a couple of slides that I want to go through with you all today, and much of this is a review from previous weeks. So again, when we assess someone to be at high or low risk, we would issue a mandatory home quarantine order. And those are the same types of orders that we've used many times. What we've developed new for Ebola is the order to submit to self-monitoring. And these are used in individuals who have come from one of the 3 countries that Dr. Quillis mentioned where there is ongoing Ebola transmission but have no known direct exposure with an Ebola case. So currently there are multiple persons in Iowa under orders to submit to self-monitoring, and we continue to anticipate that we'll receive at least 4 new traveler notifications each week. When new counties receive traveler notifications, I contact that county to discuss the orders and the procedures in detail. We do have a developed procedure document for local public health partners, but we've held off on releasing that because we are anticipating any day that new federal guidance on returning travelers will be released. That said, we do not think that we will make any significant changes to our procedures, but we just want to make sure that we're using consistent language so that doesn't cause confusion when folks are looking at the Iowa document versus the national document. So again, we've been holding off on releasing that because we're hearing that that national document should be released in the next 24 to 48 hours. So once that's released, we'll update our document and we'll get that out to all of you. But again, if you have a returning traveler to your county in the interim, we will absolutely have a conference call with you. We'll go through everything, answer any questions or concerns that you might have. We've had a couple of just learning points along the way. For example, we're learning that almost all of the travelers, but not everyone, received a thermometer. So when you do go out to issue the orders, we recommend that you're taking a thermometer with you, one with a digital readout. You can use preparedness funding to purchase those types of thermometers. So that's one learning point we had. And then also, for example, some travelers were advised to be taking axillary temperatures. We're not recommending that. We want oral temperatures, and so we're re-educating individuals on how to take those temperatures properly. One thing that we've had questions on, and this will be included in that procedure document, but I just want to go over that verbally because I'm sure you're all having questions about this in your communities. This is related to, can we tell our response partners if we have someone in our community who's under the order to self-monitor? And we do think that it would be appropriate to tell the hospital, the appropriate EMS service, possibly your emergency managers, in a confidential manner that there's someone under orders in your county, but we would not, we do not recommend, we ask that you do not provide the patient name or address. Again, we would recommend you share this information in an effort to make sure that everybody's reviewed those protocols, those procedures, and is comfortable with them should the need arise. But again, these people are under orders. So part of that order is that if their temperature rises, even between the 12 hours shifts in which they're being monitored, they're required to contact our department, and at that point we'll work with that individual to further assess symptoms and make sure that any healthcare provider where this patient would present or be transported to, any transport system would have ample time to take a deep breath, prepare, make sure that protective equipment is being used. And so again, sharing this information would not be something we're recommending from the standpoint of we're concerned the patient may just show up somewhere, because again, they're required to notify us. It's more as a pretty gentle push to make sure everybody's got their procedures in place and have practiced. I'm going to leave the discussion of the public release of this information to Polly. She'll be talking with you in a couple of slides. So at this point, I'm going to turn things over to Steve Mercer to talk about personal protective.
Right. Thank you, Dr. Garvey. Just to bring to everyone's attention, the CDC did release some enhanced guidelines for personal protective equipment, and on the slide that you see in here is actually the title of it, and I think the title is very specific. Again, it's the guidance on personal protective equipment to be used by healthcare workers during management of patients with Ebola virus disease in U.S. hospitals, including procedures for putting on or donning and removing or doffing, and it's dated October 20th, 2014. The link is where you can get a copy of this multi-page document, but what I wanted to do is just take a couple minutes and just go through some of the highlights on that. Currently, the new enhanced guidance they talk about is based on 3 principles, and these 3 principles are was learned from watching healthcare workers at the University of Nebraska, at Emory University, and at the National Institute for Health, and it follows a lot of their guidance they have in there. But the 3 main principles are going to be based on the idea that there's no skin exposure when PPE is worn. All healthcare workers undergo rigorous training and are practiced and competent with PPE, including donning and doffing procedures in a systematic manner. All workers will be supervised by a trained monitor who watches each worker donning and doffing PPE. And also some of the recommendations are that this trained monitor also watches these individuals while they're doing patient care to help with that. But CDC is continuing to recommend all the same PPE that was included in the August 1, 2014 guidance, with the addition of coveralls and single-use disposable hoods. Goggles are no longer recommended, as they may not provide complete skin coverage in comparison to a single-use disposable full-face shield. And additionally, goggles are non-disposable. They may fog up after extended use, and healthcare workers may be tempted to manipulate them with contaminated gloved hands. PPE for recommendation for healthcare workers caring for patients with Ebola include double gloves, boot covers that are waterproof and go out at least mid-calf or leg covers, single-use fluid-resistant or impermeable gowns that extend to at least mid-calf, or coveralls without an integrated hood, respirators, including N95 respirators or PAPRs, single-use full-face shields that are disposable, surgical hoods that ensure complete coverage of the head and neck, and an apron that is waterproof and covers the torso to the level of the mid-calf, and then again that covers the top of the boots and the boot covers. And that should be used if Ebola patients have vomiting or diarrhea that you are taking care of. The guidance does also describe different options for combining PPE to allow a facility to select PPE for their protocols based on availability, healthcare personnel they're familiar with it, comfort and preference, while continuing to provide a standard high level of protection for the healthcare personnel. The guidance goes on, and just a few more points in here, includes having 2 specific recommended PPE options for the facility to choose from. Both the options provide equivalent protection if worn, put on, or removed correctly. The facility should also have a designated area for putting on and taking off PPE, And the facility should ensure that a space and layout allows for clear separation between clean and potentially contaminated areas. The other major change in this is the trained observer to monitor the PPE use and safe removal. They also recommend that there are step-by-step removal instructions and both instructions for donning and doffing that this trained observer would read and have a physical checklist at the same time. And then disinfecting any visible contamination of the PPE using the EPA registered disinfectant wipe prior to taking off the equipment. And then disinfecting of the gloved hands using either the EPA registered disinfectant wipe or an alcohol-based hand rub between each step in removing the PPE. So again, those are just some of the major highlight changes in that, but that document, again, is available out of the CDC's website, and it would be of value for everybody that's going to be involved with that to download and take a look at it. Ms. Polly Carver-Kim.
I see we have a lot of questions coming in on the webinar, so I'll keep this short so we can get to your questions. I did send out a new press release template last week regarding Ebola preparation, and if you did not receive that and you'd like to get it, let me know and I'll make sure you get it. I sent it out to the local public health agencies listserv that I have. Also, we are sending out another press release from the State Department later this week or early next, comparing influenza to Ebola. So if that is something that you'd be interested in having a local version of that as well, let us know. We can work on that for you. And you can go to the next slide. Here's what we're sharing about return travelers and health orders. Starting this afternoon, we will be posting a weekly update on our Ebola webpage. As part of that update, we will have a count of health orders issued in the state. We'll also be listing the number of suspected cases of Ebola and cases of Ebola, and of course those are 0. But we want to make sure we put that in there because I think that will help calm down the hysteria level a little bit. And we want to make sure that you are aware of the statement that we will be providing to the media if and when they ask us, well, where is that person who has that health order? And we are only releasing state-level data. We will not release the name of the county. And that is because, and we have consulted with our Attorney General representative, here's our answer. Because of the small number of travelers returning to Iowa from Ebola-affected countries in West Africa, the release of county-level data could lead to identification of an individual, which is in violation of Iowa Code Chapter 22. So I can, that's going to be on our website. We can also share that statement with you via email. I can shoot you off an email to all the local public health agencies in case you get a question or a call. You know, and I guess we just wanted you to be on the same page as us where that's concerned. And also a reminder that you should not release county level data either. So if, of course, you'll know if there's someone in your county who has a health order issued, but do not confirm that, that you have one in case you get a call from the media. And if you get that call and you start to feel your blood pressure rise, give me a call and I'll help you handle the reporter. And that's my update.
All right, I think we're ready to start taking questions. Again, we have quite a few. One question was, will we make these slides accessible? And we'll go ahead and post those to the HUN. We'll just have a folder on the HUN where we put our weekly update slides in there. So if you'd like to use those when you're talking to your community members, feel free to do so. There's a lot of questions kind of related to the state stockpile and how that supply is released. So I let Steve, we're trying to figure out who should take this one. Steve's going to go ahead and take this question.
Right, there are procedures in place that we can release product out of our stockpile in a response mode. So we would not be able to release any of the material during the planning process and everything. It would only be during a response. And also, if you actively had a patient, there are procedures for that. And again, it just follows the same pathway as what we used in H1N1, where the request would come through your local emergency management. And we will post those guidelines. We'll put that document again out on the out on the share drive that has those procedures in place for you. And I know that there's also a couple questions that seem to be about some specificity in some of the PAPR hoods and everything. And we're doing our best to see if we can try to identify some other sources and all for that. And we'll keep you posted on that.
Okay. So the next one is who would be under the quarantine order versus high and low risk. So I'm happy to take that one. So if we deem that someone, and deem that's collective, our discussions with local public health partners, that someone is under a low or high risk, which basically means they had direct contact with an Ebola infected patient, we would put that individual into assuming they're asymptomatic, into a mandatory home quarantine. And people who have just returned from one of those 3 countries in the last 21 days but had no known contact with Ebola-infected patients, that person would go under an order to submit to self-monitoring. Basically, under that order, the individual has to report to local public health twice daily and report whether they're having any symptoms and take their temperature and report their temperature reading. That report can come in through a telephone, through a text message, or through an email. Now, the quarantine, if we were to have someone in a mandatory home quarantine, we would be monitoring that person in person twice daily. And at this point, the individuals that have traveled into Iowa have all fallen into that lower category of being under an order to submit to self-monitoring. So the next question is, do we know when CDC will be releasing clinic guidelines and algorithms? And we anticipate that that guidance will be released in the next 24 to 48 hours. I know that you've all been waiting on it just as much as we have. I think CDC is trying to push things out as quickly as possible. As you all know, they're fighting this issue abroad and here in the U.S., and so we need to be a little bit patient with them as they try to put this guidance material together under tight timelines. We know it's in the works. We're as anxious for it as you are. So as soon as we see it, we'll make sure that we're mentioning it to you all. So the next question is, if local public health finds out about a traveler. So this comes in a different method from the CDC notification. And maybe I should back up and just remind folks how we're finding out about these travelers. So all travelers coming from one of the 3 countries where there's ongoing transmission are now required to fly through one of the 5 airports in the U.S. where there is screening occurring. So that's Newark, JFK, Chicago, and Atlanta in Newark. And so when persons go through that airport, they are screened. And CDC is using the EPIX system, which is a system we've had for years. It's the same way we get notified of measles exposures on airplanes, to send that information to us. When we get that, we reach out to the appropriate health department. I am going to pause here and say, if we get that notification after hours, late at night, which that is sometimes occurring, or if we get it on Sunday, we wait until the next business day to do that follow-up, because that person has already been screened once, and we're talking about a matter of hours. So unless we find out that this person is at high risk or there's reason for specific concern, we will contact you the next business day if it comes in after hours. So again, that's the system in which we're getting those notifications. If you locally find out that someone came in, and that is possible that someone came in still within 21 days, but prior to this screening being implemented at the airports, we would ask that you call us, and we will work with you on putting that person under the appropriate order. So again, if you find out through your means that there's someone in your community who came in prior to the screening or somehow kind of slipped through the cracks, give us a call. We want to make sure that we have that person under order. So we have a question about how would a hospital know if a person is under self-monitoring orders if that person lives in a different county?
Yeah, if the person is under self-monitoring orders, as soon as they develop a fever or any other symptom consistent with Ebola, they are under orders to contact public health immediately. And at that point, then we will, as Ann said, take a deep breath, determine what is the most appropriate action to take, and we would give people a heads up if this person needed to go to get an ambulance ride, if the person needed to show up at a hospital. Those places will be notified ahead of time, and hopefully we're talking about hours, so that they can get ready, they can feel comfortable with what they're doing, perhaps even take a run through with their PPE and make sure that they're all ready to go before the patient would ever show up. That's one of the purposes of doing all of this, putting people under orders, is just trying to make sure that we don't have somebody just showing up at the last minute and saying, by the way, I might have Ebola. We want to prevent that from happening, so that's the point of all of this.
Great. We have a couple of questions that are asking, it's along the same lines as what we were just speaking about, whether there will be additional guidance for clinics, for emergency rooms who are just screening patients who come in. And our understanding, again, is yes, in the next 24 to 48 hours, we could expect that guidance, PPE recommendations, because, again, the guidance that has been circulated is primarily for taking care of hospitalized confirmed Ebola patients. So, again, that screening guidance should be out shortly. A lot of the questions we're getting are pretty similar to the ones we've already answered.
Option between N95 and PAPR, either one is acceptable.
Yeah, someone asked, is there an option between N95 or PAPRs? And the answer to that is yes. Either one is acceptable in the updated guidance from CDC. A lot of comments of individuals having trouble finding certain personal protective equipment, and that's something that we're hearing nationwide. And so we may get additional information from CDC on that as part of our regular calls, and we'll make sure that we are passing that information on to you.
There's a question about talking about norovirus as well as influenza with Ebola. And that's a good point, because as we know, Ebola can sometimes present as diarrhea and vomiting, which is like norovirus, so we'll take that into consideration, especially now that we're starting to see norovirus go up too. Thank you.
Okay, the next question, I think they're just really wanting some clarification on who we can tell and what we can tell related to persons under orders. And again, we've had a lot of comments from all of you that you want to be able to tell your response partners that there is somebody under order in your community, so that they can make sure that they're able to kind of have all their ducks in a row. And so we are comfortable with that as long as they're told in a confidential manner and that no patient names or addresses are provided. As far as public notification, as Polly mentioned, we will only be providing statewide counts of persons under orders, and we will not be releasing countywide data, and ask that you do not release that information as well. There's a question about if private businesses have a person returning from one of these 3 countries and they put the person under a quarantine order. I mean, I guess I'd like to just step back and say, again, public health will be notified of persons returning from these 3 countries as they transit through the airport system. And at that time, we will assess the risk of the individual and put them under orders accordingly. Every person who has been in one of these countries in the last 21 days will be under an order of some kind. Most will be under the order to submit to self-monitoring. So if individuals decide to take additional more restrictive measures on their own. If they decide that they want to home quarantine, I guess that's their decision, but that's not a public health requirement as long as they don't meet the high or low risk criteria. So I think we answered that question.
Can I just add, I am a little bit hesitant at a school or a business or any kind of facility on their own making requirements of their workers that are not scientifically based. I mean, anybody can voluntarily do what they want, but I think we all need to try to be as consistent as possible. It's one of the things that causes confusions. For example, if you have one business doing one thing and another business doing another, you're going to get a lot of people then very confused out there about what the science really is. So I would just stress that our recommendation would be for us to be the ones, the public health officials, to be the ones who determine what really needs to be done to protect the public, and just go with that, not each individual place trying to decide that they're going to do things differently. I think that that causes too much trouble and is not necessary. Can someone request a facility? Okay, and this question does come up about whether or not it's a facility quarantine or home quarantine. Our law states that a quarantine must be applied in the least restrictive manner. Now, in the past, when we've had people who, for example, have been exposed to measles or TB, that usually meant the person stayed home. So we would have the person just stay at their house, et cetera. And I think given all other things being equal, we would continue to ask these people to stay at home. Now, if somebody said, my family doesn't want me to stay at home or whatever, if there's another place that they wanted to go to or a friend's house or something, again, as long as it was voluntarily on their part so that they would agree it was the least restrictive manner, we would allow that as long as it did not present any additional risk to the general public. So when these things come up, we certainly will work with the person who is going to be placed under quarantine and do it in a way that is appropriate. But the problem with putting somebody in a hospital is that person now is taking up a hospital bed and they're not ill. So that is probably not what we would do.
There's another comment about being a little unclear on when we would use quarantine versus self-monitoring. If you still have questions about that, why don't you give us a call? Again, the bottom line is if someone had contact with an Ebola-infected patient, we'd put them under a mandatory home quarantine. If they were just in one of those countries and didn't have direct contact, then we would put them in order to submit to self-monitoring, and that's the big difference. There are some questions about enforcement of those orders. Under the order to submit to self-monitoring, if the individual does not comply with that order, specifically in the order we state that they will be required to go into a home quarantine, and if they don't comply with that, it is a simple misdemeanor enforceable by law. So those are official orders, both types. Are there any changes between public health assessment in the home environment? On previous webinars, we've talked about kind of what we're asking public health to do during these assessment processes. I can go through that really quickly, but again, if you have detailed questions, please reach out to us. The bottom line with the order to submit to self-monitoring, in those situations, we do ask that local public health make initial contact with that individual, make sure, go through an assessment, a series of questions to make sure that person truly fits into that known exposure to an Ebola-affected patient category, and then goes to the individual's home or where the individual is staying, has the individual sign the order, does education, and teaches the individual how to take their temperature if there's any need for that. And after that initial visit, as long as the individual is reporting at the designated times, and again, that's important to designate 8 and 8 or 9 and 9, as long as the individual is complying and reporting, there wouldn't need to be another home visit from local public health. If anything does not go right, if the person does not report on time or we're unable to find the person, that's not been an issue yet, but if that occurs, then we want to be hearing from local public health immediately, and we'll work through that process with you. And this is the type of information that I go over with each public health department as they get their first return traveler. So again, we'll go through all of this with you when we work through that with you. Now with the mandatory quarantine order, we are asking that public health go to the home twice daily to see the patient, visually see the patient take their temperature. So when we did that assessment, we'll do the same assessment we did with the persons under the order to self-monitor and make sure that they fit into that high or low risk category. We'll do the initial at-the-door visit with the person, discuss how to take their temperature, and so on. So on the subsequent visits, local public health will need to go to the door, tell the person to put the thermometer in their own mouth, turn it around so that you can see the digital readout, and then you'll document that, and then you'll be able to just verbally ask them if they've had any symptoms or illness. And that's the procedure. So you won't need to go into the home or try to examine the patient. You won't have any hands-on with that patient, so you shouldn't need any PPE in that situation either. If a person under an order decides that they want to talk to the media or go public, is it okay to talk about that? Can we confirm that? And the answer to that is no. Patty, go ahead.
I'll just say this has happened in the past, and the bottom line is even if the person self-discloses, we're still under the law that says we cannot identify anybody, so all you would be able to say is we can't confirm or deny, Joe Smith is under quarantine or anything. It sounds sort of funny, but the bottom line is the law would still pertain even if the person self-disclosed.
The next question is, what if a patient lives in a border county or a traveler lives in a border county? We'll work with our neighboring states to make sure they're aware of someone. If they live in Iowa but they work in Illinois or Nebraska, we'll work with that border state to make sure that our counterparts at that appropriate state health department are aware of the situation. We'll just deal with that on a case-by-case basis. The next question is, do we prefer that the local health department monitoring a suspect case takes an oral temperature versus a temporal scanning?
And the answer is the best way of taking a temperature in these type of situations would be an oral temp. We would just ask that the person monitoring it in person or teaching the patient how to do it, if it's going to be self-monitoring, just teach them how to do it correctly so they get a correct temperature. One of the things I'll just say here is, what if it's very slightly elevated? And we've had that come across in times past, just because somebody, if they just had a hot drink or something like that, can actually increase their oral temperature slightly just because they just had something hot in their mouth. Best thing to do is just ask them to wait a while and then repeat the temperature and make sure that they that their temperature either goes down, or if it continues to stay up at that point, then that would trigger our response. But most of those cases, the temperature is going to go right back down again as they stop drinking a hot drink.
One question is about, is it possible for persons to fly into Mexico or Canada and then drive across the border? And we're not hearing that that's happening, but certainly that's possible, and that's another reason why, if you get information from your community members about persons who may have been in one of those 3 countries, that we want to work with you to make sure those individuals are under orders.
The one thing I just add is most other countries are doing this initial screening also, so there might be, if somebody stopped off, for example, in Canada for several days before coming to the United States, we may be notified of that by the Canadian authorities also.
So we talked about most of the next ones. There was a note that the new emergency department algorithm was released this past weekend. Yes, that was one of the things that Dr. Clemens had mentioned in the slides. But our understanding is, again, that there will be more detailed screening PPE recommendations to accompany that document. So that is a great document, but more details should be forthcoming. List of approved disinfectants, and there is environmental cleaning guidance on CDC's website. It's linked from ours. so if you have any questions about that, again, it points out bleach and then some of the products approved for non-enveloped viruses. We know Ebola is, or excuse me, for enveloped viruses, we know Ebola is a non-enveloped virus, but we're recommending that they use those enveloped virus disinfectants because they may have better efficacy. Just trying to scan here. We have quite a few repeats. Can you provide a quick okay.
Sure. There's a question about it. Any recommendations for healthcare worker quarantine after caring for a patient? Yes, one of the things, once we have a known person with Ebola confirmed, one of the things we'll do is go back in time to find out anybody that they could have exposed after they began having symptoms, and obviously that will include healthcare workers. Then as we go forward from that time, as the person is cared for, CDC will be sending a team into that hospital to work directly with all of the healthcare workers to assure that they use the proper precautions and PPE. But should a healthcare worker get exposed, indeed that person would be treated like anybody else that was exposed to a patient with Ebola. Now hopefully that doesn't occur, that the proper PPE would be used, etc. But if it did occur, that person would go into 21 days of quarantine just like anybody else.
Okay. Different. So we're just trying to scan here.
What about EMS services that serve 2 or more counties? Certainly one of the things we're talking about with EMS is any EMS service that might be called to the place where the patient lives. That EMS service should be notified that there is somebody in their response area that is under some type of quarantine or self-monitoring order, so that they get a little bit of a heads up and can make sure they're prepared. But again, just want to reiterate, you would not share with them the patient's address. They would just need to know. And we do understand that some EMS services go across county lines.
So the next question was related to, will the state send teams to hospitals if we have a confirmed Ebola patient? And again, Dr. Clint, go ahead.
Yeah, I was just going to say, we would obviously be very, very involved in that, but it's our understanding that CDC would send a team of experts who have been through this multiple times before and worked in hospitals where they have had Ebola patients, et cetera. They would be the experts that would be working directly with that hospital. So while we would be involved, it would not be us going to the hospital. It would be the CDC experts.
The next question is, how would we respond if a returning traveler had no exposure, who had no exposure, refuses to submit to self-monitoring? Again, if that is an order, there is law behind that. And so if the individual does not comply with that order to submit to self-monitoring, they would be put into a mandatory home quarantine. And if they don't comply with those orders, it is a simple misdemeanor. So that is something that's enforceable by law. Has the template been sent? So we are getting questions about the self-monitoring template. We'll put that on the HAN as well, so that if you haven't seen that, you can see that. In that same folder, we'll put the assessment that I mentioned that we asked local public health to go through on the phone prior to doing that at-the-door assessment to make sure that individuals fall into the respective risk categories. So we'll put both of those there.
There's a question about who is responsible for getting their food, medications, et cetera, if they live alone. And the law basically says once public health puts them into isolation or quarantine, we accept the burden of ensuring they have what they need to stay healthy during that time. Now, that does not necessarily mean that public health has to pay for it. But, for example, if somebody lives alone, within that 21 days, they may well need groceries, and I would want the public health people to work with them to get them the groceries. But again, there would be no reason why you would have to pay for it, but you would have to ensure that the patient has access. Same thing with any medications or anything. You need to ensure that the patient can get it. Doesn't mean you have to do it as a public health official. It could be a friend or family member, but you have to make sure that the person does not go without their medicine or have to starve while they're being put into this mandatory quarantine. So just to figure out a way of doing it that's the least burdensome and make sure that they have what they want. Go on.
There's a question about can they put a sign on the person's house, and we would not recommend putting a sign on the door for individuals who are under that order to self-monitor, because again, they're going about their day-to-day activities. They're just calling into us twice daily or emailing or text messaging.
I would just say even for those under quarantine, we have used quarantine things in the past, but I would just say before you put a quarantine sign on somebody's door, I would ask you to talk to us. Because of the incredible stigma around Ebola and because of the incredible media attention, again, a person does have their right to medical confidentiality. So I would just say let's not use it unless for some reason we feel it's absolutely necessary. Let's just ensure the person is compliant but not put a sign on their door. I just think that adds too much to the confidentiality issue, and just from the media, I could just see there being 15 trucks outside their door with satellite dishes on it. Should we put some sign on somebody's door? So we can talk if you feel it's necessary because they're exposing people who come to the door or something like that. Give us a call and we'll work with you to see if there's something we need to do. But the bottom line is, I think with this situation, the answer is no. Do not put a quarantine or sign on the person's door.
Okay, I have some repeat questions about PPE for local public health when going to the door to do monitoring. And the bottom line with that is we're not recommending PPE because, again, these people that are under the order to self-monitor, they're going to work, they're in the community. These are people who haven't had known contact with an Ebola patient. Like Dr. Quinlisk mentioned, there are large parts of these countries where there is no Ebola transmission ongoing, so it is definitely reasonable that these people did not come in contact with that virus. And so, again, when we have somebody under that self-monitoring, the first time you go there, you're just having the individual sign the paperwork, making sure they understand how to take their temperature. On people who are in that mandatory home quarantine, again, you're not physically examining that patient. You're just going to the door, the patient's putting the thermometer in their mouth, they're handling the thermometer, they're taking their own temperature, they're turning it around so that you can see it, and then you're writing that temperature down and just verbally talking to the person. Again, this isn't an airborne virus, so we are not recommending PPE. And again, we're asking that anytime the individual feels ill, that they call our department and report that right away. And so there shouldn't be a situation that you walk into where the person is ill when you get there. So again, for those reasons, we're not recommending PPE. There's a question about the temperature of concern. CDC has decreased their temperature of concern to 100.4. What I'm telling the local health partners when we start these orders is just, if we start to see temperatures trending upward, we want to know that, even if it's kind of below the official threshold. And we may, in situations, recommend that the person be in their home until the next 12-hour period so that we can see whether they're becoming ill or if they just took a shower type of thing. So, there's a question about what if the patient lives in an apartment building. Again, we're not, we're asking you to go to the door, and so that's.
And this is Dr. Quinlisk. I'll just add that in Texas, where obviously they were doing, I believe, 50 or so patients where they are monitoring, they were even saying that if the weather was bad or something, that they felt it was perfectly safe for people to step inside the door and talk to the person again, though they recommend that you don't sit down, you don't touch surfaces, all of that, just in case. But they were having their people, again, without any PPE, stepping inside when the weather was bad just to get out of the rain, etc. So again, no PPE would be used in these situations, but we don't want people touching the thermometers and things like that, since that could have the oral bodily fluids on it. We want the patient to be touching that and taking their own temperature. And that's just, again, out of an abundance of caution to make sure that you don't potentially get exposed to bodily fluids.
Okay. There's a question about if an ambulance gets called to a location that has a monitoring going on, should we tell them to use extra PPE? And again, if we have somebody who's under order and they start becoming ill, we will have time to tell the EMS service that this is someone who was in one of the Ebola infected countries and we are assessing their health status, so they need to comply with the CDC recommended personal protective equipment recommendations. So,
and I would just add, we are hoping that we catch these people early enough in their illness that it might be that most of these people could drive themselves to the hospital and EMS may not even be needed. So just the other thing I just want to reiterate is most travelers coming from this part of the world, if they start having symptoms of a fever or diarrhea or something, is going to have something other than Ebola. They're going to have traveler's diarrhea or they might have malaria or something like that. We're going to treat them as if it could be Ebola, you know, to be sure, but just want to again remind you that we expect most of these people not to have Ebola. In fact, I'll just tell you, out of the, I believe it's something like 75 people who have been stalked through various travelers' screenings who have had fevers, all of them have not had Ebola. The most common diagnosis has indeed been malaria. So just to reiterate, just we want to make sure that people understand we're going to take all the precautions needed, but we still don't believe that Ebola is a high-risk disease to occur here in Iowa. A question is, would there ever be a time that public health would draw blood for Ebola test? I hate to say no, absolutely not. There might be, but I think if somebody is ill enough that we are drawing Ebola tests, that we would probably have them in some kind of a medical situation.
So there was a question about, are we meeting with ambulance services, and EMS providers statewide were invited to participate on this webinar and are invited to participate on all weekly webinars. So we have quite a few of those providers on today's session. There's a question about whether this is being archived. We will archive this webinar, and in 24 to 48 hours that'll be available if you want to share this with other providers.
Which one? Yeah, there's a question about, do you have any concerns of contamination when the person signs the paper? And remember, this is somebody who very recently, a person who very recently has been traveling on airplanes and has come back, traveled through airports, etc. So this is somebody that we probably would be talking to them, getting them to sign these within hours, at most a day or so of them traveling. So and the person, I mean, if there should be no risk whatsoever when you go in to do that face-to-face interview to get them to sign it, etc. There should not be any issue. However, I will just say, if you walk into the house and the person stands there and says, I have a high fever and I don't feel well, I would suggest that you stop the interview at that point, step out of the house and give us a call. There would be a very remote possibility that somebody might come down with symptoms between those two times, but again, no, there should basically be no, yeah. So, I don't think that's an issue. Now, do you want to answer?
No, I was just going to add too, and that's part of why we're asking that you give that patient a call before you go to the home, if possible, so that you can do that assessment over the phone first, so there's no surprises when you get there. I will tell you that there's a pretty wide variety in the level of completeness of the contact information we're receiving, and so that hasn't always been an option for everyone, but in most cases there is a valid phone number provided and you're able to do that assessment over the phone first. A lot of questions about PPE for local public health. Again, if you have remaining questions, please reach out to us and we can address those directly. So at this point, I'm just scanning through all the questions. Sure. So someone's asking for a number to call, and we are going to continue to use our 800 number. That's what we have on all of our orders, and that number is 1-800-362-2736. And after hours, our on-call system goes through the State Patrol, and that number is 515-323-4360. So make sure that if you're sharing that number with other providers in your county, you're letting them know that that goes through State Patrol, so they aren't thinking they have the wrong number. If a traveler is associated with, oops, we're getting questions popping here, with the university, would we notify student health?
Yeah, and I think it sort of depends on the situation. We certainly would notify student health that there's somebody within their system who is under this kind of quarantine or self-monitoring order. Should the person, for example, live in a sorority house where they sleep with 50 other kids in the same room or something like that, there might be things that we would do differently about putting that person into a different site for their isolation of quarantine, but that would all have to be worked out based on the student, their risk, the situation. Some of these things, obviously, they're hard to have a black and white answer to, but we certainly would somehow be working with student health, and they would at least know that there was a student.
So some questions, someone is asking whether people should be using a regular duty officer line to ask questions. And we are, at this point, that's fine if you want to use that, but we would prefer that you use the alternate number that I provided. And the number that I provided is the CADE, the Center for Acute Disease Epidemiology 1-800 number. And again, on that 1-800 number, if you call it after hours, it will tell you to dial the State Patrol for additional assistance, but I just went ahead and gave you that State Patrol number so you're not having to make an extra call if you know you're calling us outside of business hours. So at this point,
Can you let us know how many are to self-monitor? Do you want to go ahead and tell them at this point? Give them the number. Okay, good. Yeah, there's a question about, could you let us know how many people are ordered to self-monitor to date? We're going to be doing that every Sunday, and as of right now, there are 4 people in the state of Iowa that are under self-monitoring orders. We have no one, 0, who are under quarantine orders at this time.
And maybe, Polly, do you want to just explain what our cutoff is? So there may be, we are going to take as of, go ahead.
Yes, we're going to do our update every Monday, and the cutoff for the data that we'll be releasing on Monday is the Sunday before that. So yesterday was the cutoff for the information that we're providing today, and that's what we'll continue to do.
Right, so they have to be under order on Sunday, not in process, but under order. Okay. All right, well, again, we've hit the 1 o'clock hour. We appreciate your time, and again, we will be holding these webinar updates every week. And in the interim, if you have questions or concerns, please reach out to us. Let us know what we can do to support you better.
Okay, I think that will conclude today's webinar. The recording will be available in the next 24 to 48 hours, and we'll make sure that that information is also posted and sent out to the folks on the call. Thank you for your attendance today.